Hello students. In this video, I'll take you through the pharmacological actions and pharmacokinetics of antimuscarinic drugs. So, as I told you, antimuscarinic agents, they inhibit the muscarinic receptors. They are non-specific antagonists of muscarinic receptors, and the prominent effects are seen in organs which normally receive strong parasympathetic tone. So the effect of antimuscarinic drugs is largely predictable if you know the parasympathetic effects. So before we go into the pharmacological action, let's just brush through the muscarinic receptors. So muscarinic receptors are of five subtypes. M1 present in the CNS neurons, sympathetic postganglionic neurons, gastric glands. M2 myocardium, that is the heart. Smooth muscles and presynaptic sites has M2 and M3 in the exocrine glands, vessels, visceral smooth muscle, M4 and M5, they are largely found in the CNS. So in the CNS, so we'll be discussing the pharmacological action with atropine as a prototype drug. So in high doses, atropine can cause CNS stimulation. It can lead to restlessness, delirium, hallucination, and disorientation. And it can stimulate many medullary centers, vagal center, respiratory, and vasomotor center. However, scopolamine or hyoscine is another alkaloid can produce CNS depression and can produce sedation, it can produce amnesia and drowsiness. So their pharmacological actions are almost similar, atropine and scopolamine, but in the CNS, atropine produces CNS stimulation and scopolamine or hyoscine produces CNS depression. And scopolamine has anti-motion sickness property because it can depress the vestibular excitation. Atropine or atropinic drugs or antimuscarinic drugs can reduce the cholinergic tone in the cholinergic overactivity in the basal ganglia and can suppress the tremors and rigidity of Parkinsonism. And high dose can cause cortical excitation, disorientation, hallucination, and delirium, followed by respiratory depression and coma. On the cardiovascular system, at low doses, atropine usually produces bradycardia. That is due to the blockade of the M1 receptor on the inhibitory prejunctional neurons, thus permitting increased acetylcholine release. But the significant effect of atropine is tachycardia on the CDS. Higher doses of atropine usually produce significant tachycardia, that is by blocking the M2 receptors on the SA node of the heart, through which vagus reduces the heart rate. And on the blood pressure, there is no marked or consistent effect on the BP. Next, coming to the action on the eye. So atropine, it can act on the circular muscles of the iris. So if you remember the muscles of the iris, we have the circular muscles or the sphincter pupillae, and then you have the dilator muscles known as dilator pupillae. So these circular muscles are innervated by the parasympathetic nervous system, whereas the dilator muscles, sphincter pupillae, dilator pupillae is innervated by the sympathetic nervous system. So what happens with the acetylcholine, you remember, it contracts the circular muscles and produces meiosis. Whereas atropinic drugs like antimuscarinic drugs, what does it do? It actually relaxes the sphincter pupillae and produces mydriasis, that is dilatation of the pupil. So topical instillation of atropine can produce mydriasis. Mydriasis is mainly by blockade of the M3 receptors in the constrictor pupillae, that is the circular muscles. And they can also act on the ciliary muscles. Okay, they can contract the ciliary muscles. The ciliary muscles get paralyzed and it can lead to loss of accommodation or cycloplegia. Okay, so cycloplegia will be seen and the effect of atropine will last for 7 to 10 days. It can result in photophobia, it can result in blurring of near vision and abolition of light reflexes. And This mydriasis produced by atropine can block all the drainage of aqueous humor. It can increase the intraocular pressure, especially in people with narrow iridocorneal angle, narrow angle glaucoma, and can precipitate glaucoma. On the smooth muscle, all visceral smooth muscles that receive the parasympathetic motor innervation are relaxed by atropine, that is by M3 blockade. M3 receptors are primarily present in the visceral smooth muscles. So by blocking the M3 receptor, there is relaxation of the smooth muscle. So we'll see in different organs. In the GIT, it can decrease the tone and motility and can relieve spasm. So atropine and atropine substitutes, they are used as a potent antispasmodic drug. Okay, and sometimes it can result in constipation. In biliary tract, smooth muscle is relaxed and spasm, if any, is also can be relieved. Effect on the uterus is very minimal with antimuscarinic drug. On the bronchial smooth muscles, atropine causes bronchodilation and they can reduce the airway resistance, especially in patients with COPD and asthmatics. On the genital urinary tract, so it can reduce the tone of the fundus of the bladder. So this part will be relaxed and it can enhance the tone of the trigonal sphincter. Sphincter will be constricted. So it can lead to voiding, slowing of voiding, and it can lead to urinary retention. So it can be especially problematic in elderly males with prostatic hypertrophy. In the glands, atropine and antimuscarinic drug reduces all secretion except milk. So this action is by blocking the M3 receptors in the exocrine glands. Sweat, salivary, nasopharyngeal, tracheobronchial, and gastric secretions are decreased. Skin and eyes become very dry. Talking and swallowing may be difficult because of reducing of the secretions, but does not produce a striking inhibition of the lacrimal secretion, antimuscarinic drug, and they have very little effect on the pancreatic and intestinal secretions. Body temperature can increase. That increase occurs at higher doses, and children are highly susceptible to what is called as atropine fever. So atropine, when given to children, they can develop what is known as atropine fever. It can be due to inhibition of sweating. Secretion is reduced, right? So sweating will be reduced and stimulation of temperature regulating center in the hypothalamus, which is contributing to hyperthermia. And atropine has mild local anesthetic action on the cornea. So another paradoxical response of atropine, it can produce blockade of the release of the inhibitory muscarinic autoreceptors on the nerve terminal. If you remember this figure, we had discussed this figure while discussing the cholinergic neurotransmission. This is the cholinergic uh, presynaptic cholinergic nerve terminal. Okay, so we have acetylcholine synthesized and stored in these storage wafer cycles, and there is release of acetylcholine into the synaptic cleft. It can act on the receptors. These are postsynaptic receptors on the effector organs by which it produces the response. Now, there are receptors, autoreceptors present on the nerve terminal. Okay, so when you block these receptors, okay, they are usually inhibitory. Okay, so blockade of inhibitory muscarinic autoreceptors can lead to enhanced acetylcholine release from certain postganglionic parasympathetic as well as sympathetic nerve endings, and they can produce paradoxical response. Okay, what we saw bradycardia in low doses is due to blockade of this receptor, autoreceptors on the presynaptic junction. Atropine usually has high affinity for exogenously administered cholinergic drugs rather than the parasympathetic, increasing parasympathetic tone. And the sensitivity of different organs and tissues varies and can be treated as, sweating, salivary secretions, bronchial secretions are reduced. That has high affinity for atropine. Then intermediate activity against eye, bronchial muscles and heart, and then comes the smooth muscle, intestine, bladder, and least for gastric glands and smooth muscles. And scopolamine we discussed before. Scopolamine or hyoscine, they can depress the reticular activating system and usually produce euphoria, drowsiness, amnesia, and dreamless sleep, which can last for 1 or 2 hours. And scopolamine is effective in motion sickness because, that is because of its direct action on the vestibular function. So if you have to compare atropine and hyoscine, these are the two alkaloids. Source of atropine is Atropa belladonna and Dechuras flammonium. Hyoscine is leptin from Hyoscyamus niger. Structure, if you see, atropine is an alkaloidal ester of tropic acid with tropine, whereas hyoscine is ester of tropic acid with, scopin and tropic acid, whereas atropine is tropic acid with tropine. And the CNS effects, atropine produces CNS excitation or stimulation, whereas scopolamine and hyoscine produces CNS depressant action. Atropine has more potent anticholinergic action on the heart, bronchial smooth muscles, and intestine, whereas hyoscine has more potent action on the eye and secretory glands. Duration of action of atropine is longer, whereas hyoscine or scopolamine is shorter. Now coming to the pharmacokinetics. So pharmacokinetics of atropine and hyoscine, they are rapidly absorbed from the GIT and parenteral sites as well as the mucous membrane. They can freely penetrate the cornea and passage across blood-brain barrier is somewhat restricted. About 50% of atropine is metabolized in the liver and rest is excreted unchanged in the urine. They have a T-half of 3 to 4 hours, whereas hyoscine is more completely metabolized and has better blood-brain barrier penetration. With that, we come to the end of pharmacological action and pharmacokinetics of antimuscarinic agents. Thank you.